First off, many, many thanks for inviting me to this kind of small, compact gathering. It's a real thrill to be here, and it's great to hear that methodology is getting talked about. Unfortunately, I'll have to sit down to present this because I have a bad back at the minute, and it's much easier for me, so apologies for that. I'm just going to spend a few minutes just kind of giving a gentle introduction to some of the issues, many of which have already been briefly mentioned, just to get you thinking about what the quality of the various evidence generation methods are. We've heard about randomized trials, but there's a huge amount to be learned from observational data. And then we're going to hear 4 presentations which encompass a wide range of different methodologies. So this is really just to get everybody on the same page, just to wake you up after the morning coffee, and get us to be thinking about why design in these research studies is of crucial importance. The focus of the talk will be on randomized trials. That's because my background is a trialist, but I think it is also useful to think about randomized trials as the gold standard and then put up other designs against that to critically assess what the strengths and weaknesses are. As I say, non-randomized investigations are very important, and there are massive difficulties with randomized trials. They're expensive, they're time-consuming, they can be very selective in terms of the patients that are included. Very often, as methodologists, we say these designs have high internal validity, but possibly a much lower external generalizability. And we've seen during the COVID pandemic, really how difficult it was to produce at scale large numbers of randomized trials that informed or changed clinical practice. There were some very, very good ones, and recovery and solidarity in particular, but generally speaking, my take would be that we didn't do enough trials, and we didn't do them on the right issues, and we didn't do them quickly enough. So I said I would contrast a surgical trial with a drug trial. For better or worse, most of the architecture that we have for assessing randomized evidence comes from drug trials. There is this classic building blocks for for any kind of study, the so-called PICO structure of population, intervention, control, and outcomes. And there is this very straightforward linear development in the drug world through the various phases, phase 1, phase 2, phase 3, phase 4, where you proceed in a kind of organized fashion, there are no surprises, and you end up with unimpeachable evidence that will inform best practice. I think it is important to bear in mind there is a fundamental distinction between explanatory and pragmatic randomized trials. Explanatory or efficacy trials are given ideal conditions, given the perfect surgeon, given the perfect patient, given perfect operating environment. What is the maximum benefit that you can generate from that surgical technique? And that's contrasted with pragmatic effectiveness studies where you're interested in, okay, that's how much you can generate, benefit and harm you can generate, but what actually gets generated under real-world conditions? What is actually with imperfect surgeons, imperfect patients with a host of comorbidities, and problematic operating environments? What's the actual benefit that you generate? I think probably the most important differences are in this first slide. Pretty much the only challenge you have in a drug trial is getting the person to take the drug. All of the drugs are manufactured to high standards, they're transported. Pretty much any pill that you get anywhere in the world will be the same as the same pill anywhere else in the world. And that's clearly not the case with surgical trials. In the surgical trial, the subject is randomized to a procedure. and the procedure is given by human beings, a surgical team. The quality of that intervention will vary according to many factors, some of which we've already heard about, encapsulated in the so-called learning curve. In a drug trial, you may be taking the intervention over an extended period of time, possibly for life. It's entirely possible that there is crossover from one drug to another, be they either crossing over from what we've been randomized to or even other drugs within that class. Surgery, on the other hand, putting aside repeat operations, surgery is usually a single procedure. And it is entirely expected within surgical trials that for good reason, people are not going to get what they were randomized to. When you get the person on the table and you start the procedure, clinically it may be very necessary for you to switch into a different intervention. We've heard about blinding. In drug trials, this is the gold standard. This is where the notion of a placebo-controlled trial comes from. Blinding, some people say, is usually possible, and the choice of outcomes is usually obvious in these trials. Very often in surgical trials, blinding is not possible, and also the outcomes are often not intuitive. You have the obvious issue of measuring technical success of the operation, but if you think of it from the patient's point of view, what is the thing that they're most interested in? Is it their quality of life, say at a distance of 12 months after the operation? It is not as intuitively obvious. I should just say on blinding, it's a peculiar thing that so much importance is attached to blinding. It is an important source of bias, but it is just one of many. And I often see as a methodologist drug trials where huge effort is put into ensuring a blind, and yet there are very obvious signature side effects which effectively unblind the study and can influence the assessment of outcomes, and that seems to be overlooked. The drug delivered in a drug trial, the delivery, as I said, is identical for all participants, but here we have the problem of learning curves. And as my colleague said earlier on, there's the issue of ascending the learning curve, then you hope to reach a plateau, but I would also argue that there is the issue of then, sadly, people descend the learning curve as they become complacent or de-skilled in terms of their skills in the surgical room. This is a big problem in surgical trials, how to deal with the learning curve. There is a school of thought that says you should only compare a new treatment with a standard treatment when the learning curve is ascended. But there is a contrary view, certainly popular amongst patient groups, that the learning curve is an integral part of the surgical experience and shouldn't be discounted. As new surgeons come in over the decades, they have to learn these procedures. And if the learning curve is very difficult and long, and only a fraction of people actually attain that plateau, that should be taken into account. Finally, I would like to close on arguing that it's very important that surgical trials are considered differently in terms of safety. Nearly all of the architecture for safety is generated from randomized trials, so-called pharmacovigilance, and it is a very poor match trying to map that into the context of surgical trials. The process is not externally defined, and very often the follow-up, where the adverse events are going to occur, if relevant, takes place not in the surgical context, but in the community. That's a little bit about analysis. It is, of course, obligatory that you analyze the surgical trial according to the design. Sadly, we still, as people reviewing, even in the reviewing papers, even in the high impact journals, you still see cluster randomized trials analyzed as individually randomized trials. You still see surgical trials. designed to account for the learning effect, the learning curve, but absolutely no mention is made of it in the analysis. And this is a situation that needs to improve. I mentioned the ideal collaboration because this is a very good and long-standing attempt to imitate or replace that nomenclature of phase 1, phase 2, phase 3, phase 4. It's continued to be refined. We had a session at the Royal College of Surgeons in London on extending the ideal collaboration to placebo-controlled surgical trials, which, as you can imagine, was quite an interesting get-together. And I'll just finish in conclusion to say, critical thing is that both randomized and observational designs can produce high-quality evidence, but both can produce low-quality evidence. There's nothing magical about putting the word randomized into a study design. It doesn't mean that it's going to be better than an observational study. It has to be designed well, and it has to be executed well, analyzed appropriately. And vice versa, some registry-type data, some observational data, if it is curated to a very high degree, if it's kept inclusive rather than exclusive, these designs can produce very, very useful data. They also produce that data quickly and generally at low cost. So that is two very, very important considerations to take into account. Surgical randomized trials do have specific procedures. We've had a whistle-stop tour of some of those. But I would say, having been in the business of doing trials, surgical and otherwise, for the last 3 or 4 decades, developing the best design is critical to success. You must give yourself the time to design the study. It is next to impossible to rescue, during the execution, a badly designed study. And also, please, the analysis and reporting need to be appropriate and well applied. So hopefully that's teed you up to have an even more critical assessment of the fantastic studies that we're now going to hear about in the remainder of the session. Thanks.
Thank you very much. I think we can go on and discuss later on the application. The next speaker is Frederick Schaub, and she's